So, good afternoon, friends, colleagues, and students. Now, we all are going through very hard, sad, and grim times. COVID-19 is taking a toll on us, physically, mentally, and emotionally. The harsh reality is that we are losing our loved ones, we are losing our colleagues. When we see the number of physicians who have already died due to COVID-19, it's heartbreaking. And if you look at the list of the cardiologists, Dr. Moinuddin, Dr. Monwar, Professor Mujibur Rahman, and the list goes on. You can't bear it. So today we are gathered here, first of all, to pay our respects to them and to pray for their departed souls. And we also want to pray for all our friends, colleagues, and students who are at present suffering from COVID-19. We pray that they have a swift and total recovery. And lastly, I think we need to pray for ourselves also, so that we stay safe and that we are spiritually, mentally, and physically all right. And talking about mental health, I think we decided to have this discussion mainly to boost our mental health, to think about something outside of COVID for a change. And what did we choose? We chose mitral stenosis. Now you might ask, why mitral stenosis? My answer is why not? Because for every exam that you sit, you will be asked questions from mitral stenosis. You'll be asked about mitral stenosis as a long question. They'll give you a scenario and you have to deduct that this was mitral stenosis and prove it through your investigations. In the OBSP, you might get an ECG, an X-ray, or an echo, where you would have to diagnose mitral stenosis. In the instruments, you might get a broken bora needle or a Mullen's sheath or even the Inu balloon. When there's a short case, be sure that some of you will get a mitral stenosis case. And for a long case, maybe you'll get a 35-year-old young female with left-sided hemiplegia who, when you auscultate, you find a mid-diastolic murmur. So mitral stenosis, it is one of the most cornerstones, I can say, of cardiology. So that's why we decided that we're going to discuss about mitral stenosis. And today we've got, some fantastic speakers. We're very lucky to have them, and they will be talking to us about certain aspects of mitral stenosis. So once the discussion or lecture ends, we will have some question answers and then go to the next speaker. So that's how we want to proceed. So our first speaker is Dr. Kalimuddin. And for those of you who know him, he needs no introduction, of course, but for those of you who don't know him, he's one of the most brilliant academicians of National Heart Foundation. And not only that, he is the most hardworking doctor that anyone has seen. No one can work as hard as Dr. Kalimuddin. So without further ado, I will request Dr. Kalimuddin to go with his first presentation. Dr. Kalimuddin.
Honorable moderators and learned audience, Assalamu alaikum. I am presenting etiology and pathophysiology of mitral stenosis. Mitral stenosis results from thickening and immobility of the mitral valve leaflets, causing an obstruction in blood flow from the left atrium to left ventricle, resulting in increased pressure in the left atrium, pulmonary veins, and right side of the heart. Mitral stenosis is a continuous, progressive, lifelong disease, usually consisting of a slow, stable course in the early years, followed by progressive acceleration later in life. Mitral valve apparatus consists of four components: mitral annulus, two leaflet, anterior, posterior, chordae tendineae, and papillary muscle, anterolateral, posterior papillary muscle. There is mitral annulus and anterior leaflet, posterior leaflet, chordae tendineae, and there is anterolateral papillary muscle and posterior papillary muscle. Normal pressure in the left atrium is 4 to 12 millimeter, and end diastolic left ventricular pressure is 4 to 12 millimeter, and pulmonary systolic pressure is normal 15 to 30 millimeter mercury. Etiology of the mitral stenosis. Most common cause is rheumatic fever. Other rare causes are severe mitral annular calcification, congenital causes parachute mitral valve, supravalvular mitral ring, systemic disease, which causes valvular fibrosis like carcinoid disease, SLE, rheumatoid arthritis, drugs, methylsurgery therapy, fenfluramine, radiotherapy for chest or breast cancer, restrictive mitral valve repair for mitral regurgitation, and as a component of Gutenberg syndrome with axial septal defect. Epidemiology: approximately 25% of patients with rheumatic heart disease have isolated mitral stenosis, and approximately 40% have combined MS and MR. Only 50% have reported past history of rheumatic fever. The main age of symptom onset in developing countries in between the third and fourth decade. Mitral stenosis is primarily a disease of women with a 3:1 female preponderance. The main pathology in rheumatic mitral stenosis is commissural fusion, which is the hallmark of the disease. Leaflet thickening and caudal fusion and shortening lead to typical fish mouth appearance. Pathophysiology of mitral stenosis: narrowing of the valve area to less than 2.5 cm² typically occurs before the development of symptoms. Mitral stenosis causes obstruction to the left atrial emptying, which leads to difficulty in left ventricular filling and increased LA pressure, which is reflected back into pulmonary venous circulation. Normal pulmonary venous circulation pressure is 9 to 12 millimeter. When this pressure exceeds 18 millimeter mercury, then interstitial edema occurs. When with further elevation of pulmonary venous hypertension more than 25 millimeter above oncotic plasma oncotic pressure, then fluid leakage, there will be leakage of fluid from interstitial space to alveoli and leads to pulmonary edema. Increased pulmonary venous pressure subsequently causes increased pulmonary artery pressure, and pulmonary arterioles causes secondary vasoconstriction, and there is vascular change in the pulmonary vasculature, which leads to severe pulmonary hypertension, and at times severe pulmonary hypertension results in right-sided heart failure with dilatation of the right ventricle and its annulus with subsequent tricuspid regurgitation, and in some cases tricuspid pulmonary regurgitation. When mitral valve area greater than 1.5 cm² usually does not produce symptom at rest. However, if there is an increase in transmitral flow or a decrease in the diastolic filling period, there will be a rise in left atrial pressure and development of symptoms. Thus, the first symptoms of dyspnea in patients with mild MS are usually precipitated by exercise, emotional stress, infection, pregnancy, or atrial fibrillation with a rapid ventricular response. This graph shows normal pressure curve between LA and LV. In mitral, in the early phase of diastole, there is minimal transmitral gradient, but subsequently throughout the distal, there is no transmitral gradient. But in mitral stenosis, there is a gradient between LA and LV. This table shows stages of mitral stenosis, which is ranging from a patient at risk of mitral stenosis A to progressive hemodynamic obstruction stage B, and to symptomatic severe MS, asymptomatic severe MS stage C, and symptomatic severe MS stage D. Each of these stages is defined by valve anatomy, valve hemodynamics, the hemodynamic consequence of valve obstruction on the left atrium, pulmonary circulation, and symptoms. At stage A, there will be mild diastolic doming of the anteroleaflet of the mitral valve. There are normal transmittal flow velocity and no hemodynamic consequence and symptoms. At progress stage B, there will be mitral valve leaflet doming in addition to commissural fusion. Planimetry mitral valve area will be more than 1.5 cm². There will be increased transmittal flow velocity, mitral valve area more than 1.5 cm², and diastolic pressure half time less than 150 milliseconds. Mild to moderate LA enlargement and normal pulmonary pressure at rest, and there is no symptom. In asymptomatic severe MS, there will be valve anatomy as same as progressive mitral stenosis, only will be progressive in nature. Mitral valve planimetry will be less than or equal to 1.5 cm² in case of severe MS, and equal or less than 1 cm² in case of severe MS. Regarding valve hemodynamics, there will be same parameter valve area, but diastolic pressure half time will be equal or more than 150 milliseconds in case of severe MS, and 220 or more than 220 in case of very severe MS. There will be severe LA enlargement and elevated pulmonary artery systolic pressure more than 30 and no symptom. In severe symptomatic mitral stenosis at stage D, there will be same parameters as asymptomatic severe mitral stenosis, only there will be symptom, decreased exercise tolerance, and exertional dyspnea. Thank you.
Great, thank you. So we just learned about the basic pathophysiology of mitral stenosis. We learned that due to the stenosis, the valve takes a fish mouth appearance. We plan to learn more about this echo findings from Tuhin at a later time. And we also learned that there is a back pressure, and we have had some great graphs where we showed that the gradient gradually increases, and then first you have asymptomatic patients, and then as the gradient increases between the LA and the LV, you get more symptoms and you get more back pressure, and the symptoms arise. So we have questions. So does any of the speakers or anyone have any questions? Otherwise, we do have some questions here. And one question is, okay, so these are not questions, these are rather like some great initiative. So thank you for appreciating our initiative. We are grateful for that. So my question would be to Kaleem. So a patient has a mitral valve area of 1.5, and another patient has a mitral valve area of 1. Okay, so which one would be called severe mitral stenosis?
Now, there are two guidelines, American ICCH guideline and European ESC guideline. This ESC guideline decided that there is, if there are three parameters for disease severity. In mild MS, there will be mitral valve area less than 1.5 centimeter square, and moderate is 1 to 1.5 centimeter square, and severe less than 1 centimeter square. And there will be transmitral gradient from 5 millimeter up to 5 millimeter, mild, 5 to 10 it is moderate, and above 10 millimeter mercury it is severe. And pulmonary systolic pressure they considered, and if pulmonary systolic pressure less than 30 it is mild, 30 to 50 it is moderate, and in case of severe MS it is more than 50. But in ACCH guideline, they decided in 2014 guideline, they changed their grading severity. Why they changed grading severity? They defined severe MS as which symptom occurs, and as well as which symptoms intervention improve these symptoms. So they decided MS, severe MS as mitral valve area less than 1.5 centimeter square, and they considered then one less than 1 centimeter square it is very severe, and it is if patient they considered in symptomatic and asymptomatic. They considered they divided patient disease progression of the rheumatic valvular heart disease at 4 stages. As I mentioned, stage A, stage B, stage C, and stage D for indication of PTMC or valvular surgery.
Yes, I want to pass my exam. What do I say? 1.5 or 1? I mean, maybe easy answer would be like 1.5 is severe and 1 would be critical, something like that, right?
Very severe, yes, very severe.
Okay, very severe or critical, right? So,
guideline.
Another thing in exams, try to keep your answers short and simple. Otherwise, the examiner might also get. Okay, we've got another question for you, Kaleem. The question is, could you tell us something about parachute valve, parachute mitral stenosis? What does that mean? Because you might get
parachute mitral valve is a congenital disease. There is only one papillary muscle which attached to with leaflet with corda. So there will be only single papillary muscle. It is usually in human, there is in adult there is two mitral papillary muscle, anterolateral and posterior. But in case of parachute mitral valve, only one papillary muscle.
Okay, we have a question that would be more relevant to Tawfiq, but you can just touch it and then we'll go to the next speaker. The question is, how many times can you do PTMC? I'm sure Tawfiq is going to elaborate on this, but Kaleem can just sort of give an inkling.
PTMC,
how many
PTMC
times
can be
PTMC?
PTMC can be done repeatedly if until morphology of valve permitted. But
so that is in a nutshell, one single line answer, that it can be done repeatedly if the morphology of our valve allows us, right? Okay, yes. And Tawfiq will be going into details on that. So this is the first lecture. Kaleem is going to come back again at a later time. So now we have our second speaker. Now this second speaker is very special because he always has a smile on his face. Today he's a bit tense, so he's not smiling, but he is a person that I've known like 30 years now, more than 30 years. So always I've seen him with a smile, and he is the most kindest person that I know. And he is someone who's very eager to teach. So Dhiman will be telling us about uh, his presentation now. So Dhiman, go ahead. Please start, Dhiman.
Yes. Respected moderator, teachers, and colleagues and friends. My presentation is today on clinical presentation.
A bit louder. Dhiman, just a bit louder.
My presentation is on clinical presentation, physical findings, and ECG and X-ray. Most patients of mild mitral stenosis are asymptomatic. Moderate to severe mitral stenosis patients are commonly symptomatic. Some conditions that produce precipitate symptoms are infection, anemia, atrial fibrillation, hyperthyroidism. Emotional stress may produce symptoms of mitral stenosis, and pregnancy. All these conditions give rise to increased cardiac output and hyperdynamic circulations, which produce symptoms of mitral stenosis. The prominent symptoms of mitral stenosis, among that, dyspnea is the most prominent. It may have varied presentation. Some may present with exertional dyspnea, some with paroxysmal nocturnal dyspnea and orthopnea. Hemoptysis is an important symptom of mitral stenosis. I will elaborate this later on. Some patients with mitral stenosis have chest pain. 15% of the patients with mitral stenosis had chest pain. This chest pain may be due to severe right ventricular hypertension secondary to pulmonary vascular disease, and this patient may have concomitant coronary obstruction. Palpitation may cause, as there is LA enlargement, there may be tachycardia, atrial ectopics, or atrial fibrillation. As the LA is left atrium is enlarged, there is microthrombus or visible thrombus present in the left atrium, and which may dislodge during left ventricular contraction, which may produce embolic events. In mitral stenosis, left atrium is enlarged, and this may so much enlarge that it give compression to the left recurrent laryngeal nerve posteriorly, and it causes hoarseness of voice, which is commonly known as Ortner syndrome. Hemoptysis, 10 to 20% patients with mitral stenosis present with hemoptysis. Frank occurs in exercise. This causes increase in cardiac output to double and the transmitral gradient to quadruple, which causes sudden increase in left atrial pressure. This causes rupture of small pulmonary vein anastomosis, leading to frank hemoptysis. This is also known as Gordon formula. Rupture of thin dilated bronchial veins may produce frank hemoptysis. In mitral stenosis, as a late complication, it may produce pulmonary infarction with heart failure. It may also cause frank hemoptysis. Mitral stenosis may cause acute pulmonary edema as a severe complication, which may produce frank sputum, which may be due to rupture of the alveolar capillaries. These are the physical signs. I am going to the physical signs. It is the mitral phasis. In severe mitral stenosis, there is low cardiac output with systemic vasoconstriction causing to pinkish purple patch on this cheeks. And I have give here two pictures, one with fair complexion and one with dark complexion of our country. Arterial pulse may be normal in sinus rhythm, and it may produce irregular pulse in atrial fibrillation. Blood pressure is usually low. The pulse pressure of the blood pressure is reduced due to low stroke volume. In mild mitral stenosis, jugular venous pressure is normal. In moderate to severe mitral stenosis, it produces increased jugular venous pressure, and there is a prominent A wave in sinus rhythm, which is due to forceful RA contraction against a hypertrophied non-compliant RV. In presence of AF, this A wave and the X descent of the J wave, jugular venous wave disappears, and there is only a crest A prominent or V or CV wave per cycle. The apex beat of the mitral stenosis, the left atrium, left ventricle reveals inconspicuous in mitral stenosis. Tapping apex is associated with loud first sound, which suggests the anterior mitral leaflet is pliable. There may be a diastolic thrill which is palpable in left lateral recumbent position. RB lift is present, which is due to right ventricular hypertrophy and pulmonary hypertension. The pulmonary component of the second heart sound is palpable in the second left intercostal space. In auscultation, it is very important for examination purpose. The S1, there is loud first heart sound. Accentuation of the loud first heart sound occurs when the mitral valve leaflet is flexible. If the mitral valve leaflet is calcified or thickening is more in the mitral valve leaflet, there is the reduced amplitude of the first heart sound. So the first heart sound is less audible in case of thickening and calcification of the mitral valve. So it is an important clue of mitral valve calcification. Pulmonary component of the second heart sound is become accentuated and later on become loud when pulmonary pressure rises. Gradually, the pulmonary pressure rises, the S2 splitting is narrow. The splitting means the second component of the heart sound has two components. First the aortic component and next the pulmonary component. These become narrow with rising of the pressure, and due to the pulmonary compliance of the pulmonary valve with earlier pulmonary valve closure. Lastly, the second heart sound is a single component and loud S2 is present. The opening snap to some of the author is the hallmark, one of the hallmark of mitral stenosis auscultatory finding. It is due to the sudden tensing of the mitral valve leaflet after the valve curves has completed its complete opening excursion. It is most readily audible in the apex. Calcification confined to the tip of the mitral leaflets does not produce opening snap. The distance between the pulmonary component of the second heart sound and the opening snap is a very reliable marker of severe mitral stenosis. As the duration is shorter, it is the severe the mitral stenosis. That is, the MDM is more prolonged. The differential diagnosis of opening snaps are wide fixed splitting of the second heart sound and the pericardial knock, which is found in constrictive pericarditis. This is one of the tricky common question of our examiners in mitral stenosis. The diastolic murmur, which is present in mitral stenosis, is a mid-diastolic murmur. It is a low-pitched, rumbling mid-diastolic murmur, best heard at the apex with the bell of the stethoscope in left lateral recumbent position in breath-holding expiration. The pitch and the duration of the murmur are the guide for severe mitral valve narrowing, not the intensity. You should remind it. The intensity of the murmur is not related to the severity of stenosis. Then in mild mitral stenosis, the diastolic murmur is short or brief, and it starts just after just at the beginning of the diastole, and it again resumes at presystole, and this is known as presystole. And in severe mitral stenosis, this murmur is present all over the diastole and the presystolic accentuation. This is a graphical presentation. You can see here. This is the first heart sound. This is the second heart sound. Two components: aortic component, pulmonary component. As in mild mitral stenosis, the pulmonary component is more louder, almost to an aortic component, and as it is severe, it is more louder than the A2. This is the opening snap, and the distance between the opening snap is short. As there is severe mitral stenosis, you can see the diastolic murmur more pitched, and it is more of duration, and there is presystolic accentuation. The other auscultatory findings are due to pulmonary hypertension. there is a murmur of tricuspid regurgitation, there is a systolic murmur in the left fourth intercostal space. There may be a flow, pulmonary diastolic murmur of mitral regurgitation, which is known as Gram-Still murmur. The differential diagnosis of mitral stenosis most commonly asked by our teachers. The common is LA myxoma, valval thrombus, and ASD. These three are the common. The others are in older person, there may be a diastolic rumble at the apex. These are due to the annular calcification of the mitral valve. In about 90% of the patient, if echocardiography is done, the echocardiography has no significant stenosis around the mitral valve. In severe MR, there may be a non-flow, non-stenotic mitral valve diastolic flow, which is increased. And in case of HCM, there is also a flow, diastolic murmur at the mitral valve. There is another important question regarding auscultatory findings of mitral stenosis, which is asked by our teachers. This is, what are the auscultatory findings after PTMC or CMC? The S1 may be as before. S2, the pulmonary component of the second dorsal will be decreased. The opening snap, distance between the opening snap and the pulmonary P2 will be increased. The presystolic accentuation will be soft in case of sinus rhythm, and in case of AF, it will be absent. And in case of the MDM will be, duration will be less, and the murmur will be low pitched. Next, I go to the ECG as my time is very short. This is a classical ECG of, you can see ECG, I have given an arrow mark, which is the negative component of the P wave in V1 is present, and there is almost a notching of the P wave in the lead 2. These are the features of left atrial enlargement. In this ECG, you can also see that there is right axis deviation. 2-3 AVF R is tall and 1 AVL S is tall. So it is right axis deviation. And you can see, if you see more keenly R wave in the V1, there is RSR pattern, small RSR pattern. So it is the feature incomplete RVEV. So incomplete RVEV with right axis deviation gives a feature of RBH, and there is left atrial enlargement. So this is an important ECG of mitral stenosis. Mitral stenosis patient. This is a patient, ECG is, you can see there is atrial fibrillation with fast ventricular rate. There is RBB pattern, incomplete RBB pattern in V1, and there is also right axis deviation. And 2-3 ABF, 1 AVL, you can see. This means fibrillation. This is patient's ECG of mitral stenosis. A question is commonly asked in the question, in the exam. What is the clinical scenario of this ECG? The first diagnosis will be mitral stenosis, as there is atrial fibrillation, right axis deviation, RVAV. The next differential diagnosis is, it may be a patient with ASD, but if you say ASD, then the LA must be enlarged. But in ASD, RA is enlarged. In ASD, LA is enlarged in two conditions. When ASD, there is reverse shunt, then LA is enlarged, and when there is MBP with MR. So if second differential is ASD with reverse shunt or ASD with MBP with MR. This is another ECG, important ECG, the exam ECG of atrial fibrillation. This is the patient with atrial fibrillation, and you can see the T inversion in V3 to V6 and 2 AVF, 1 AVL. In a patient with atrial fibrillation, don't commit in exam that this patient has ischemia. See for other things also. In this ECG, you can see there is inverted tick sign. You can see the inverted tick sign here, and you can see the last component of the T wave. This is the last component of the T wave. In books, it is written, if you draw an isoelectric line through this ECG, if this peak of the T wave is above this line, it is due to digoxin effect. And if it is on the line or below the line, it is due to digoxin toxicity. So you can see this is the ECG of AF with digoxin toxicity. Next, my presentation is about chest X-ray. In chest X-ray, this is, you all know this. This is the aortic knuckle, left border of the heart, aortic knuckle, pulmonary, the pulmonary artery. This is the left atrial appendage, and this is the left ventricle. The right border is formed by the right atrium most commonly, and in the upper part in the superior vena cava, and in the lower part it is the inferior vena cava. This is the LA at the mid, which may produce increase the angle of the carina in case of mitral stenosis. And in mitral stenosis, RV is enlarged, RV is this one, and this is may push the LV upwards, producing an acute angle. This is a typical X-ray I have collected for mitral stenosis. You can see this is the aortic knuckle, pulmonary artery, pulmonary conus is filled up, and it is due to increased pulmonary artery pressure. This is the right atrial enlargement, is this one, producing the straightening of the left border. You can clearly see the two borders. This is the border of the right atrium, and you can see that the other border is due to the left atrial enlargement. This is an ECG, this is an X-ray of straightening of the left border is present, and you can see the vessels, pulmonary vein are directed upwards, and it is known as upper lobe diversion. And to some authors, it is the first sign of pulmonary hypertension. So this normally the pulmonary vessels goes parallel to the chest, perpendicular to the chest, like this way. But from the upper part, this vessel rises due to pulmonary hypertension, and this is known upper lobe diversion with straightening of the left border. You see there is the double contour of the right border also. And this is the next X-ray where there is straightening of the left border, there is double contour of the right border, but there is cardiomegaly. So you can say that there is, it is the mitral valvular disease, that is in presence of mitral stenosis, there is also mitral regurgitation. This is another X-ray. You can see almost the straightening, and the pulmonary conus is burst out very much, and the right pulmonary artery is widely dilated. It is widely dilated, and heart size is also dilated. So in this X-ray, you should say there are for differentials, that is multivalvular disease. That is, there might be mitral valvular disease in associated, there will be aortic valvular disease also. And the other differentials are, it may be a patient with ASD with pulmonary hypertension. So with this, my time is also up. Thank you to my moderator for sharing.
So thank you, Dhiman. We've got quite a few questions for you. Okay. So we've got quite a few questions for you. The number one question is, what are the differential diagnoses for the opening snap? The second question is, a patient comes to you with MS and MR. How do I clinically in the exam diagnose which is dominant, MS or MR? Okay, so I can hear a mid-diastolic murmur, I can hear the pan-systolic murmur of MR as well. How do I differentiate which is the most prominent? Why do we get upper lobe diversion in the X-ray? And what are the ECG differential diagnoses of a LA enlargement? So you've got 4 questions. So could you go quickly through these questions, please? Answers.
the important differentials of opening snap are first of all, it is the fixed splitting of the second heart sound in case of ASD. In case of ASD, the fixed splitting is normally the splitting I have already mentioned. First is a aortic component, then the pulmonary component, and it varies with respiration. Normally, in inspiration, this comes slightly closer, and the P2 is slightly loud. And in ASD, there is RVBB and there is right ventricular hypertrophy. So there is a more narrowing of there is more wide, and the splitting is fixed because at ASD the left atrial pressure and the right atrial pressure almost equalizes. So there is fixed and wide splitting of the second component of the second heart sound. And in case of pericardial knock, in case of constrictive pericarditis, it is a diastolic high pitch sound. In case of constrictive pericarditis, it is the pericardial knock. It is a diastolic high pitch sound. It is due to when there is calcification in the pericardium during diastole, there is sudden non-yielding of the filling of the ventricles, and this produces a high-pitched diastolic sound in auscultation. It is known as pericardial knock. And in presence of MS with MR, differentiation of which lesion is dominant. In case in examination, if the apex beat, in case of presence of MR, apex beat will be shifted laterally. It will not be in the normal. In MS, commonly apex beat is not shifted. But in case of presence of MR, moderate to severe MR, in presence of mitral stenosis, the LV will be also enlarged, so the apex will be shifted, and this will be forceful and heaving apex. And in case pulmonary component will be loud as usual in mitral stenosis. On auscultation, this first heart sound will not be loud as mitral stenosis. It will be soft, or accentuation will be diminished. And in presence of MDM, there will be a systolic murmur, and which will best heard with the in left lateral position, and this will have a radiation to the axilla. So it will give rise, the MR is dominant. So this, and the third question, madam, third question is?
Third question is very quickly, Dhiman, because we have got other speakers. So third question is differential diagnosis of LA enlargement in ECG. Just give me one or two.
Commonly, if there is LA enlargement, this is due to diastolic overload or due to systolic dysfunction. In diastolic overload, as example is increased distance, so LA will be enlarged. In case of aortic stenosis, there will be diastolic overload, diastolic dysfunction, LA will be enlarged. And in case of systolic dysfunction, LV EDP will be more. In case of MI, when anterior MI occurs, there will be the LV systolic function is decreased, so their LVDP will be more, so the back pressure LA will be enlarged. These are the two common pathophysiology of diastolic LA enlargement in ECG.
Okay, great. There's another question actually. It's about how do you assess the severity of MS by clinical signs and symptoms? Very quickly. Then we'll go to the next speaker.
Madam, I can't hear the question.
Okay, the question is, how do you assess severity of MS by the clinical examination? Severity of MS by clinical examination. But you have already covered it, you know, like you said that the length of the murmur.
Yes, I have covered it. This question is the length, the murmur, opening snap, duration, and the.
So you've already covered that. He's already covered that. So thank you, Dhiman, for a great presentation. And yes, it's already been covered. Thank you. So great presentation, Dhiman. And now we have Professor Tuhin Haq. Tuhin is a brilliant person. She does like fantastic echoes. Her echoes are like world renowned. She's an expert, a true world-class expert on echoes. And apart from that, she happens to be a very, very gentle and nice person. So anyone who meets her falls in love with her because of her gentleness. So now we would like to learn about what we would need to pass, the amount of knowledge that we need to pass in MD or FCPS cardiology or general FCPS, that amount of echo. So Tuhin will be teaching us that. Thank you, Tuhin.
Thank you, madam, for your nice and kind introduction.
My pleasure.
So, is my slides are visible?
They are. We can see the slides very nicely. Thank you.
Okay, thank you. So, respected moderator and dear audience, my job is to present on echo evaluation of mitral stenosis. Already we know the main cause of mitral stenosis is rheumatic. So I will demonstrate the echo features of rheumatic mitral stenosis. What we see in 2D echocardiography, the anterior mitral leaflet domes in diastole. It gives the hockey stick appearance. There is leaflet thickening beginning at the edges of the leaflet. Leaflet calcification, it may also progressively involve the chordae. Commissural fusion causing narrowing of the mitral orifice, which gives the typical fish mouth appearance. There is fibrosis thickening and shortening of the chordae. Here is an example of parallaxis view. You can see the anterior mitral leaflet tip and the posterior mitral leaflet tips are thickened, and there is diastolic dooming of the image, giving the PML mobility is restricted, and we can clearly see that the chordae is thickened here. In addition, we can see the left atrium is enlarged here. Here is an example of a short axis just at the tip of the mitral valve leaflet, showing the thickened leaflet tips, and there is commissural fusion. So both anterolateral and the posteromedial commissure are fused. So mitral valve orifice becomes elliptical, and this is the typical fish mouth appearance in a patient with MS. So for evaluation of mitral valve anatomy, Wilkinson's score is recommended. And this score comprises of mobility and thickness of the anterior mitral leaflet, calcification and subvalvular thickening. It will be better understand if I explain by schema. So this is the schematic representation. Here you can see the anterior mitral leaflet and the chordae. When only the tip of the AML is restricted, then mobility is scored as 1. Here the base and mid moves normally, so there is diastolic doming. When 1/3 of the AML tip is restricted, but the base and mid moves, this is scored as 2. When more than half, that is 2/3 of the leaflet is restricted, scored as 4. And whole leaflet is thickened, as there is no mobility at all, AML does not move, then it is scored as 4. Considered on thickness of the mitral valve leaflet, when only the AML tip is thickened and only it is mildly thickened, that is thickness is about 4 to 5 millimeters, scored as 1. When thickness involves more than half of the leaflet and thickness is about 5 to 8 millimeters, it is scored as 2. And when whole of the leaflet is thickened and thickness is about 8 to 10 millimeters, then it is scored as 3. And there is extensive thickening, that whole leaflet is thickened and more than 10 millimeter in thickness, then it's scored as 4. And regarding chordal involvement, when just one part of the chordae just attached to the mitral valve leaflet is thickened, then it is scored as 1. When 1/3 of the chordae attached to the leaflet tip is thickened, it is scored as 2. When most of the chordae is thickened, then it is scored as 3. And when there is extensive thickening of the chordae with shortening, it is scored as 4. So regarding calcification, if there is a linear area of brightness, then it is scored, calcification is scored as 1. When there is multiple area of brightness, that is a scattered calcification, it is scored as 2. When more than half of the leaflet is bright, then this calcification is more, then it is scored as 3. And when whole of the leaflet is bright, that there is extensive calcification, then it's scored as 4. So Wilkinson's score, when all the scores are summed up, it ranges from 4 to 16. And score 8 or less predicts the favorable outcome of PTMC. But there is some limitation of Wilkins score. Commissural involvement is not included in this score, limited in ability to differentiate nodular fibrosis and calcification, and it doesn't account for uneven distribution of pathologic abnormality. In addition, there are some 2D features in a patient with mitral stenosis. As I already mentioned, there is dilated left atrium, there is left atrium and left atrial appendage thrombus. There may be paradoxical septal motion due to RV pressure and volume overload, and a dilated RV and right atrium. Here, parasternal long-axis view, you can see that large semi-organized thrombus attached to the LA posterior wall. Here is a short axis view showing the large organized thrombus attached to the LA posterior wall, and you can clearly see that the whole LA appendage is full of thrombus. This patient cannot recommend for PTMC at all. Here is an example of ball thrombus. Here is another example of ball thrombus in left atrium in 4-chamber view. Here you can see the spontaneous echo contrast within LA in a dilated left atrium. Here, in addition to the LA enlargement, we can see the RA and RV are also dilated. Here you can see the hugely dilated left atrium with full of spontaneous echo contrast. So for assessment of MS severity, M-mode, 2D echo, and Doppler criteria are used. 2D echo, MVA by planimetry, and among the Doppler criteria, MVA by pressure half time and peak and mean gradients are frequently used. MVA by continuity equation and by PISA method are not routinely used for practical purpose. Measurement of PSP from TR velocity is used to see the hemodynamic significance of mitral stenosis. Here on the left-hand side, you can see the M-mode feature of normal mitral valve, and on the right-hand side, you can see the stenosis mitral valve. So stenosis mitral valve, there is decreased EF slope, and there is loss of A wave, and there is anterior motion of the posterior mitral leaflet, and the relation between AML and the PML is fixed throughout the diastole. Leaflet thickens, we can clearly see, and there is some area of branches which indicates that there is calcification in the leaflets. MV by planimetry is the best correlation with anatomical area measured at leaflet tip in a plane perpendicular to the mitral orifice. Here, mitral valve orifice looks elliptical, and by tracing this orifice, we get the mitral valve area. So here is color flow jet. We can see the turbulent mitral inflow, just typical candle flame appearance. To get the mitral valve gradient, apical 4-chamber view is used, and color flow here guides to identify the mitral inflow, and continuous Doppler is placed at the tip or just below the mitral leaflet parallel to the Doppler flow to derive the Doppler spectral pattern of transmitral flow velocity. And by tracing the dense signal, we get the maximum velocity, maximum pressure gradient, and the mean pressure gradient. Heart rate to be mentioned in each patient. To measure mitral valve area by pressure half time, time for pressure to fall to half is the original peak value is calculated from the deceleration slope. So this is the deceleration slope. By tracing this deceleration slope, we get the mitral valve area. Mitral valve area is equal to 220 by pressure half time. Regarding definition of mitral stenosis severity, Dr. Kolim has already mentioned there are 2 guidelines. So this is important for classification. So I will highlight again that according to the 2014 AHA and ACC guideline for the management of valvular heart disease, a valve based on area is considered normal when the area is 4 to 6 centimeters square, and it is considered progressive when the area is more than 1.5 centimeters square, and it is considered as severe when area is equal to or less than 1.5 centimeters square, and it is considered as a very severe when it is less than or equal to 1 centimeter square. Thus, a patient with MS is considered to have severe MS when mitral valve area is equal to less than 1.5 centimeter square, resting mean pressure gradient equal to more than 10 millimeter mercury, and pressure half time equal to more than 150 millimeter mercury. There is another classification, as Dr. Kolim has already mentioned. Why we point out this classification? because in Bangladesh and India, we follow this classification, and especially Indian Academy of Echocardiography recommend this. So according to this classification, a specific findings is on valve area. So when valve area is more than 1.5, we classify it as mild MS. When it is between 1 to 1.5, we consider it as moderate MS, and less than 1 centimeter square is considered severe. And there is some supportive finding for this classification, that is mean gradient less than 5 supports mild MS, 5 to 10 supports moderate, and when gradient is more than 10, it supports presence of severe MS. And PSP is calculated as a supportive finding to see the hemodynamic consequence. So when it is less than 30, it supports mild MS, 30 to 50 moderate, and more than 50 supports that this MS is severe. So what is the role of stress echocardiography? Stress echocardiography is to unmask symptoms in case of mitral valve area less than 1.5 centimeter, and when there is no or doubtful complaint. When there is a discrepancy between resting Doppler and clinical findings, semi-supine exercise during echo is preferred to post-exercise echo. Mean mitral gradient and PSP to be assessed during exercise. Mean gradient more than 15 millimeter mercury with exercise is considered severe. A PSP more than 60 millimeter mercury on exercise is considered as an indication for balloon mitral valvotomy. During DSC, mean gradient more than 80 millimeter mercury with stress is considered severe MS, but is less physiological. So physical exercises preferred, that is semi-supine bicycle exercise. 3D echocardiography has higher accuracy than 2D echo. Detailed information of commissural fusion and subvalvular involvement can be easily assessed by 3D echo. Mitral valve measurement in calcified and irregular valve is possible with 3D echo, and immediately after balloon mitral valvotomy, measurement by the 3D echo is more accurate and reliable. The most common use of transesophageal echocardiography is to exclude LA or LA appendage thrombus before PTMC, and occasionally TE is used to guide transeptal puncture or for positioning of the balloon during PTMC. So what is the role of echo during PTMC? To guide the transeptal puncture, to help in detecting acute complication like atrial or ventricular perforation and tamponade, whether there is an acute mitral regurgitation, whether there is a valvular disruption, and to assess the valve area immediately after PTMC. Planimetry is ideal. Pressure half time should not be used immediately after PTMC. So these are the practical points for evaluation of MS, and I like to thank all the participants for attending the session.
So thank you for the great presentation. And I have just two questions. One is, what is the difference between mitral stenosis and mitral annular calcification? And the other question is, do you stress echo and 3D echo in National Heart Foundation? I know that you do transesophageal, but do you do stress echo and 3D echo as well in Heart Foundation? So two questions.
Of course, we do 3D echo and stress echo in National Heart Foundation, and stress echo, the semi-supine exercise echo and the diaphragmatic stress echo, we do not do for evaluation of MS and to unmask symptoms, but we use rapid hand gripping exercise to unmask the hemodynamic consequence of MS, because our practical experience that if we ask the patient for repeated and rapid hand gripping, it increases the mitral valve gradient, and it helps to unmask the symptoms and to help us to understand that this MS is hemodynamically significant. Madam, what is the other question?
The other question is difference between mitral stenosis and mitral annular calcification in echo.
Okay, mitral calcification, you can see that there is when this bright echo, and mitral annular calcification may lead to MS, but this is degenerative and elderly age. Due to rheumatic MS, as I have already mentioned, that the thickening starts from the leaflet tip. So the leaflet is thickened, there is the restricted mobility and the commissural fusion, so the mobility and the orifice becomes restricted at the tip. but the calcification starts at the base of the leaflet, at the annular calcification. So if there is extensive annular calcification, there is mitral inflow limitation, which causes that inflow limitation gives rise to the increased gradient, but the leaflet tips are not lastly affected.
Thank you. Great. So now we move to our fourth presentation. And for that, Dr. Kolimuddin is going to be back with us, and he's going to tell us the medical management of mitral stenosis. Great presentation, too. Thank you.
Thank
so now Kolimuddin will be back with us.
Respected moderators and lauded audience, again, Assalamu alaikum. I am now presenting therapy of mitral stenosis. Treatment of acute episode of rapid atrial fibrillation consists of anticoagulation with heparin and control of the heart rate response. Intravenous administration of a beta blocker such as metoprolol or esmolol or a calcium channel blocker such as diltiazem, verapamil or dioxin can be used. Intravenous amiodarone can be used to control the heart rate in patients where beta blockers or heart rate regulating calcium channel blockers cannot be used or have not been effective. Rate control in atrial fibrillation, in case of chronic atrial fibrillation, adequate rate control is a cornerstone of good therapy. Beta blockers and heart rate regulating calcium channel blockers are the mainstay, while dioxin may be added if optimal heart rate control is not achieved. Resting heart rate less than 80 beats per minute and exercise heart rate less than 100 beats per minute is recommended for symptomatic patients. Anticoagulation therapy. Anticoagulation with vitamin K antagonist is recommended for mitral stenosis patient with atrial fibrillation, paroxysmal, persistent or permanent, with a prior embolic event and a left atrial or left atrial appendage thrombus. INR should be maintained to 2.5, ranging from 2 to 3 for an indefinite period. The use of anticoagulation in patient with sinus rhythm and large LA diameter more than 50 mm mercury or those with spontaneous echo-contrast may be beneficial, but has not been adequately studied. The efficacy of the novel oral anticoagulant agents in preventing embolic events has not been studied in patients with mitral stenosis. Heart failure, anemia, fever, infection, and hyperthyroidism should be corrected. Diuretics and dietary salt restriction are usually effective in treating congestive symptoms. Dioxin may be useful in patients with left and or right ventricular dysfunction. Whether beta blocker are useful in treating heart failure symptoms remain controversial, but beta blocker may be used in case of increased heart rate. Ivabradine, a negative inotropic agent, may have an advantage over beta blockers in patients with sinus rhythm. ACT, AHA, and NICE guidelines currently do not recommend effective endocarditis prophylaxis. Secondary prevention of rheumatic fever should be continued, and maintenance of optimal oral health essential. There are two types of mechanical therapy. One is percutaneous intervention and another is surgery. PTMC or percutaneous balloon mitral valvotomy (BMV) is a treatment of choice if there is no contraindication. And there are three types of cardiac surgery: closed mitral valvotomy or CMC, closed mitral commissurotomy, open mitral valvotomy (OMV) or OMC, open mitral commissurotomy, and mitral valve replacement. There are summary of recommendation for mitral stenosis intervention according to ACC among AHA guideline 2014. There are one indication for PTMC, class 1 indication for PTMC. PTMC is recommended for symptomatic patient with severe MS, that is stage D, and favorable valve morphology in the absence of contraindication, that is absence of left atrial thrombus and moderate to severe MR. And there are 1-2A indication. PTMC is reasonable for asymptomatic patient with severe MS and favorable valve morphology in the absence of contraindication. And there are three 2B contraindication. PTMC may be considered for asymptomatic patient with severe MS, stage C, and favorable valve morphology who have new onset of atrial fibrillation in the absence of contraindication. PTMC may be considered for symptomatic patient with mitral valve more than 1.5 cm square. If there is evidence of hemodynamically significant MS during exercise. And PTMC may be considered for severely symptomatic patient NYHA class 3-4 with severe MS, mitral valve, and who have suboptimal valve anatomy and are not candidate for surgery or a high risk for surgery. And there are two class 1 indications for surgery. Mitral valve surgery is indicated in severely symptomatic patient NYHA class 3-4 with severe MS and who are not high risk for surgery and who are not candidate for or failed previous PTMC. Concomitant mitral valve surgery is indicated for patient with severe MS undergoing other cardiac surgery. And there are 1-2A indications. Mitral valve surgery is reasonable for severely symptomatic patient with severe MS provided there are other operative indications. And there are 2B indications for surgery. Concomitant mitral valve surgery may be considered for patient with moderate MS, that is mitral valve area 1.6 to 2 centimeter square undergoing other cardiac surgery. And mitral valve surgery and excision of the left atrial appendage may be considered for patients with severe MS who have had recurrent embolic events while receiving adequate anticoagulation. This is indication of for PTMC and mitral valve surgery in clinically significant mitral stenosis according to ESC guideline 2017. They recommended PTMC is indicated in symptomatic patient without unfavorable characteristics for PTMC class 1 indication, and another class 1 indication is PTMC is indicated in any symptomatic patient with a contraindication or a high risk for surgery. And they have also 2A1 indication. PTMC should be considered as initial treatment in symptomatic patient with suboptimal anatomy, but no unfavorable clinical characteristics for PTMC. And they have also two groups of class 2A indication for asymptomatic patients. Those patients with high embolic risk, history of systemic embolism, dense echo contrast in the LA, new onset or paroxysmal atrial fibrillation, and or high risk of hemodynamic decompression. That means systolic pressure, pulmonary systolic pressure greater than 50 millimeter mercury at rest, or need for major non-cardiac surgery, and desire for pregnancy. Unfavorable characteristics for PTMC can be defined by the presence of the several of the following characteristics. Clinical characteristics are old age, history of commissurotomy, New York Heart Association class 4, permanent atrial fibrillation, and severe pulmonary hypertension. Anatomic characteristics are echocardiography score more than 8, coronary score more than 3, and very small mitral valve area and severe tricuspid regurgitation. Contraindication for PTMC: mitral valve area more than 1.5 centimeter square, except where symptoms that cannot be explained by other cause, and if anatomy is favorable, then mitral PTMC can be done if mitral valve area more than 1.5 centimeter square. Left atrial thrombus more than mild mitral regurgitation, severe or bicameral calcification, absence of commissural fusion, severe concomitant aortic valve disease, or severe combined tricuspid stenosis and regurgitation requiring surgery, concomitant coronary artery disease requiring bypass surgery. And complication of PTMC are severe MR requiring surgery 2%, embolic even 1%, cardiac perforation 1%, mortality approximately 1% in experience center. This graph table showing advantage and disadvantage of mechanical therapy. Advantage of PTMC are percutaneous approach, it is local anesthesia, good hemodynamic results in selected patient, and good long-term outcome. Disadvantages are no direct visualization of valve, only feasible with flexible non-calcified valves, contraindicated with MR grade higher than 2 class. Advantage of closed mitral commissurotomy or CMC are inexpensive, it is relatively simple, good hemodynamic results in selected patient, and good long-term outcome. Disadvantages are same as PTMC, only surgical procedure with general anesthesia additional disadvantage. Advantage of OMC are visualization of valves allow direct valvotomy and concurrent annuloplasty for MR if feasible. Disadvantages are only best results with flexible non-calcified valves, surgical procedure with general anesthesia. And valve replacement, advantage of valve replacement are feasible in all patients regardless of extent of valve calcification or severity of MR. But disadvantages are surgical procedure with general anesthesia, prosthetic valve muscle continuity on left ventricle.
Solima, we can't see your slides anymore. Is it finished?
Yeah, finished, ma'am. Thank you for.
Okay, fine. Thank you. So there was one question for you, and that is, can we give rivaroxaban to mild and moderate MS patients?
There are no study regarding no randomized control trials regarding rivaroxaban newer oral anticoagulant and versus warfarin had been performed. So they all guidelines, ESC among AHA guidelines, not recommended patient with mitral stenosis and atrial fibrillation newer anticoagulant agent.
Great, thank you. So now we move to our last speaker, Dr. Tawfiq Shahriar Haq. He is the person who has established structural heart disease intervention in Heart Foundation Hospital. He does on a regular basis ASD device closures, the PDA device closures, VSD, and so he is a very good candidate to today talk to us about PTMC. So a great operator and a very great orator as well, Dr. Tawfiq Shariar Haq.
Thank you, madam, for your kind introduction. So, first of all, I would like to congratulate the examinees for doing so well in the exam on mitral stenosis so far. That's why you have reached the part where you will be asked about PTMC and other small but very important topics like pregnancy issues, Gutenberg syndrome, juvenile mitral stenosis, etc. So it's my responsibility to walk you through these topics and try to make your score from good to excellent. So as Kolim Bhai was saying, PTMC, percutaneous transeptal mitral commissurotomy, is a very difficult intervention to perform. This is not my statement. This is a statement of my mentors and teachers who are doing more than 1,000 PCI per year. So why is it so difficult? Because you are actually trying to puncture a septum and dilate a valve which is not visualized. You are playing with a 70 centimeter long 21G needle in a cardiac chamber. On one side there is a thin RA wall, and on the other side there is a high pressure aorta. So there is very low margin of error, and it is only feasible with favorable valve morphology. So why are we doing this? Because it's a percutaneous approach. You can do it through local anesthesia. You can avoid cardiopulmonary bypass, and it gives good acute and good long-term outcome as well. So what are the indications? As already has been said, it is recommended for symptomatic patients with moderate to severe mitral stenosis. You have to have a favorable valve morphology. There cannot be any LA thrombus, and it can also be done in cases where valve morphology is not so ideal, but in which patients surgery carries risk of adverse outcome, like patients are suffering from pulmonary or renal or neoplastic diseases. Queen Madam has already given account about the favorable valve, so I'm not going into it. So the contraindications are mitral valve area is already more than 1.5 centimeters square. If there is LA thrombus, if needed, we have to go for transesophageal echo to ensure that left atrial appendage is free of thrombus. If there is more than mild or moderate mitral regurgitation, if there is commissural calcification, or if there is severe concomitant valvular or coronary disease requiring surgery. First of all, we have to have a know the reference size of the balloon we are going to use. It is calculated from patient's height, its height in centimeter divided by 10 plus 10. We usually use the Inouye balloon, and Inouye balloon has a unique structure. It has double layered latex balloon, which when inflated dilates in an organized manner. First the distal part gets inflated, then the proximal part giving it an hourglass appearance, then finally at full inflation the mid segment will dilate for the commissurotomy. We start this procedure by taking two punctures, an artery and a venous puncture. So arterial puncture usually 6 French, and venous puncture is taken with a larger sheath, 8 or 10 French. We must remember the balloon we are going to use is mounted on a 12 French catheter. So first we do an angiogram if it is indicated. Then we take a end-hole catheter, the multi-purpose or right RC catheter to the pulmonary artery. Then we take a picture catheter to the arterial puncture into the non-coronary sinus, and we record pulmonary artery pressure and the aortic pressure. This is how this looks. And at the upper panel is the aortic pressure, at the lower panel is the pulmonary artery pressure. Then with the help of a J-tip, these steps will be asked to some of you. Please remember the sequence. So every time you introduce something and you exchange it for another thing, this sequence you need to remember. First of all, you take a J-tip wire, Terimo wire, and a Mullin sheet and park it in the subclavian vein. You already have a pictorial catheter in the aorta. Then you take out the J-tip Terimo wire and introduce a broken burr. You can see the broken burr needle going in. The tip of the broken burr needle is a few centimeters, a few millimeters back from the tip of the Mullin sheet. then you have to pull back the whole assembly from the subclavian vein up to the fossa ovale. It is said that you will feel 3 bumps, one with the subclavian vein junction with the superior vena cava, then superior vena cava and right atrium, and then at the fossa ovalis. Once you have reached the fossa ovalis, if you gently press it, you will feel a throbbing pulsation from the right atrium. Now you check your position through AP and lateral views. You can see, you can compare with the cartoon on the right side. In the lateral view, your Mullin sheath should look away from the pectoral catheter and looking towards the vertebral column. Once you are sure about your position, you gently apply sustained push on the broken borough needle, and you will feel a subtle jump. You can see and feel a subtle jump of the needle, and suddenly the pulsation you are feeling will be released. Then you put some contrast media, slight contrast media, and you are sure about your puncture, and you keep your needle still and push in the Mullin sheath, and then you withdraw your needle and do a LA graph. So through the LA graph, you are going to see the whole of the LA appendage, and you try to have an idea about the location of the valve. Now you need to put in a spring wire which swells into the left atrium, and then you take out your Mullin sheath. This is the next step would be this is a groin and septal dilator, which is 12 French usually, to make your easy for your balloon to pass, and you dilate the septum as well as the groin. Then this is the Inouye balloon that is coming into the left atrium. Once it is in the left atrium, you must remember that this balloon is kept stretched and slenderized with a stretching stylage. Once I'm in the left atrium, I'm going to take out the balloon stretcher and push the balloon to a loop into the left atrium, and then take out the spring wire. At this point, we are going to measure the LA and LV pressure. Look at this, how beautifully it has matched, as Ruhin Madam was saying. We did a hand gripping for this patient during the regular echo, and the mean pressure came to around 13 or 14. Here also you can see this is the LV EDP, and this is our LA pressure, and giving it around 13 or 14. Now we take a balloon shaper in. The shaper is going to direct the balloon through the mitral valve into the left atrium. We have kept our pectoral catheter in the left ventricle to measure the LV EDP and see the pressure changes. Once we are in the left ventricle, we are going to inflate it, and see how sequentially it's inflating. First the distal part, then the proximal part, then the base. As soon as you have dilated, this is the time of regulation. Now, if you have chosen your patient correctly, and if you have done a good procedure, the patient is going to, if asked, to tell you that she or he is feeling lighter on the chest, and at the same time you will see a subtle increase in the aortic pressure and drop in the LA and pulmonary pressure. But if you have created complication, patient is going to start having shortness of breath due to acute mitral regurgitation. Patient might complain of aphasia, weakness of one side due to detachment of undetected thrombus, or patient may have convulsion from arrhythmia. After this PTMC, again, you can see on the right panel how nicely the pressures have come down, and both almost there is no gradient, as we can compare it with the echo. This is the aortic pressure which has risen. There is a certain small rise in the aortic pressure from our previous. And if you have created an MR, in that case, you are going to have a CV wave like this in your pressure tracing. If you have created an MR, and this is the normal wave we can usually see. After that, we introduce the LA pressure and complete our procedure. So complication we have already discussed. There are going to be hemopericardium if you are puncturing any of the walls or vessels. There may be detachment of undetected thrombi leading to stroke. There can be acute mitral regurgitation and arrhythmia. Now, one important issue is pregnancy with mitral stenosis. As has been said in the first lecture, that there is a 3:1 preponderance, and you are likely to get many patients with mitral stenosis and pregnancy, where mitral stenosis has been diagnosed for the first time in advanced pregnancy. So mitral stenosis is responsible for most of the morbidity and mortality of rheumatic heart disease during pregnancy. Moderate and severe mitral stenosis is poorly tolerated. The rate of morbidity, including fetal growth restriction or preterm birth, rises with severity of MS. Now, please remember, when you are dealing with a pregnant woman with mitral stenosis, you are dealing with a woman who has higher plasma volume, higher heart rate, higher stroke volume, higher cardiac output, and low systemic vascular resistance. And you're also dealing with a fetus who is probably facing growth retardation and defective organogenesis. You're dealing with a mitral stenosis and its complication as well, like pulmonary hypertension and atrial fibrillation. So it is really a very complex situation. You have to treat everything one by one. So pulmonary hypertension, maternal mortality ranges from 30 to 70%. There is fetal loss. Mother is most vulnerable during the time of labor and delivery. In severe pulmonary hypertension, it is recognized early in pregnancy. We may even advise for termination of pregnancy. Pulmonary vasodilators may be helpful in symptomatic patients. Atrial fibrillation causes hemodynamic compromise and lead to heart failure, stroke, or even death. So we must continue our medical therapy with a rheumatic fever prophylaxis, rate control with beta blocker or digoxin, offloading the patient with diuretics, and preventing complications with anticoagulation. At the same time, we must remember the precipitating factors. If the patient is anemic, we have to treat that. If the patient has any infection like urinary infection, we have to correct it. If the patient is hyperthyroid, that treatment has also to be given. Now, what about digoxin in pregnancy? Digoxin has a long history of safe and effective use in pregnancy. It crosses the placenta, but it is not teratogenic. It will only be teratogenic if it crosses toxic dose in the mother and cause miscarriage and fetal death. How about anticoagulation? A double-edged sword. Consider and in pregnancy, it is a prothrombotic state with 5-fold increase in risk of venous thromboembolism. And if the patient is atrial fibrillation, this risk increase further. And if you give anticoagulation, there is chance of fetal loss, embryopathy, and bleeding. But still, you have to do something. There is increased risk of miscarriage, hemorrhage, hemorrhagic complication, including postpartum hemorrhage with anticoagulant. Data has shown during the first trimester, warfarin causes embryopathy, and throughout the pregnancy, it can also cause fetopathy. So warfarin should be avoided during the first trimester. Organogenesis occurs up to 8 weeks. So up to the first trimester, it's better to avoid warfarin. And also in the last few weeks of pregnancy, when there may be emergency need for surgery. And in between second and third trimester, low dose warfarin may be continued. And low molecular weight heparin is the best alternative in the first and last trimester. And please remember to look at the efficacy of low molecular weight heparin. You have to check for activated factor 10 level, not APTT. And about delivery, vaginal delivery should be considered in patients with mild mitral stenosis. Cesarean section is considered in patients with moderate or severe mitral stenosis with higher NYHA class and severe pulmonary hypertension. Intervention, the best time to intervene is the 4th or 5th month. By this time, organogenesis is complete, thyroid is not still active, and the volume of the uterus is still small, so there is a greater distance between the fetus and the chest. I think I have bored you all already. So just to have a relaxation, here is a case I'm going to share with you. This is a 24-year-old lady who came to us in the 24th week of pregnancy with features of volume overload and right-sided heart failure. Her mitral stenosis was first diagnosed during that time. So we gave her aggressive medical management, controlled her symptoms, and took her up to 35th week. At this time, we had a joint team of with obstetricians and neonatologists and planned an intervention. So this is our PTMC team. This is the PTMC being done. You can see the lead shield covering the uterus. This is the ellegraphy after puncture. This is the dilatation of the mitral valve. And this is the echo. Look how nicely the valve has opened up. And their standby was our obstetric team, who immediately did a cesarean section. The whole procedure was done under general anesthesia though. So we have, this child is now almost 9 years old, and the mother had another baby during this time. So this was a unique experience. We have 4 or 5 cases like this. So after pregnancy, another important issue that we need to discuss is the Luttenbacher syndrome. This is a combination of ostium secundum atrial septal defect with rheumatic mitral stenosis. Patient may sometimes give a history of rheumatic fever. These patients usually presents with exercise intolerance. The pathophysiology goes like this. There is a non-restrictive ASD which allows the LA to decompress and thereby relieving the pulmonary venous hypertension. The low cardiac output in severe MS is further reduced by left to right shunt, but on the other hand, there is RA and RV enlargement and overload. On clinical examination, JVP is raised with a wave, and other features of ASD like cardiomegaly, palpable P2, and a systolic flow murmur at the base will be present. But what we will not get, we will get a loud first heart sound, but the MDM and the opening snap we may miss. So most of the features will be of atrial septal defect here. So the treatment option here was usually surgical, but recently all around the world, with the device closure being done so much, a good PTMC with ASD closure with device is now done in many institutes. Another important point I would like to talk about is the juvenile mitral stenosis. So it is defined as pure predominant rheumatic mitral stenosis under the age of 20. Early onset of symptom, and this may be distressing in the fulminating course of the disease, even leading to death if not treated at proper time. The factors responsible for fulminating course of mitral valve stenosis include racial influence, malnutrition, continued smoldering rheumatic activity, tissue response to multiple attacks of rheumatic fever, and hypertensive reaction of the pulmonary vasculature. There is severe involvement of subvalvular apparatus, creating critical mitral stenosis. Usually valvotomy provides satisfactory relief, but in our center, I think in other centers, what we have seen, these teats are really small in size, and getting a small size balloon of 16 or 18 sometimes become very difficult. Valves are also soft, a very gentle dilatation is required. Another important issue for exam is mitral stenosis with associated other valvular lesions. Please remember, the pathophysiological derangements associated with the proximal valve will always mask the expression of the attributes of the more distal valves. So co-presence of mitral stenosis blunts the usual presentation of aortic valve lesion. These patients usually need thorough assessment through history, ventricular volume, pulmonary pressure, natriuretic peptide measurement, functional capacity, cardiac catheterization, and even pulmonary pressure during exercise. To be in a nutshell, if you have two severe stenosis, you have to treat both of them. If you have one severe and moderate or two moderate, then the question comes, how much impact are these two lesions creating on the left ventricle and the functional capacity of the patient. All the time we want to preserve one valve and replace another one. Like we can do open commissurotomy for mitral valve and replace the aortic valve if needed, or repair the mitral valve and do an mitral valve replacement, aortic valve replacement, because to maintain two prosthetic valves for a long time in our country is very, very difficult. Finally, I would like to say a few words about infective endocarditis. As Dr. Kolim has already mentioned, it's a low risk. It means endocarditis may rarely happen, not that it can never happen. Associated conditions are very important, like other valve lesions, congenital heart disease, whether the person is an intravenous drug abuser, etc. The current guidelines do not recommend prophylaxis, but at the same time, we must remember that the diagnosis and treatment of infective endocarditis in our country is very expensive. So if we give a dose of prophylaxis in patients who are undergoing invasive oral or urogenital procedure, it might not be so harmful. I think I will stop here, madam. Thank you very much.
So thank you so much for a great presentation. I have a few questions. Most of them have already been covered by your presentation, so I won't repeat it. There was one question is, what are the features of warfarin embryopathy?
So actually warfarin embryopathy is a very disturbing presentation. It encompasses facial anomalies like depressed nasal bridge or hypoplasia of the nasal. There are skeletal abnormalities like hypoplasia of the finger and nail. There can be mental retardation. There are congenital cardiac anomalies like ventricular septal defect or percussion of aorta. Even the patient can have bleeding disorders and mental retardation.
So thank you. So this sort of concludes our today's session, and I must thank all the presenters for doing a brilliant job. You were all phenomenal, and I learned such a lot from you. And I must also thank the audience for being so patient. We've still got like 106 of you out there. Thank you for being so patient. And most of all, I would like to thank Incepta for giving us the technical support, and especially Mr. Nurul Absar. He was so patient with us. He has been trying to teach us the nitty-gritties of how to do a Zoom meeting, and thank you for doing such a great job. And I would invite all of you for next Wednesday. Can you hear me?
Yes,
so for next Wednesday, we have mitral regurgitation, and I would request all of you to come and join us. There's going to be another group of great speakers, and it's going to be phenomenal at that time as well. So thank you for a great job, everyone. Great job. Thank you. And thank you, audience. And thank you, Mr. Nurul Absar. So we conclude now. Bye. See you all next week.
So
thank you.
Thank
Any
you.
words from the speakers? You want to say anything? The speakers, and then we can conclude. Anyone want to say anything?
I just wanted to ask to him, madam, about the role of transesophageal echo pre or per procedural, if you like to comment.
Okay, as I have already mentioned that pre-procedural echo, transesophageal echo is mostly used to exclude the thrombus before PTMC, and during valvular surgery, there's a mitral valve replacement, not so much used, but for mitral valve repair, transesophageal echocardiography is must. TE-guided mitral valve repair is essential. So most useful is to exclude thrombus before PTMC. The most useful is TE, and per procedure to guide the mitral valve repair.
In some centers, they have shown that during PTMC also. Do you think it increases the safety of the procedure if we, in critical cases, if you want to puncture and
yes, I have already mentioned that to guide the transeptal puncture, TE is useful. When I have shown the role of echo during PTMC, I mentioned that to guide the transeptal punctures. So TE during PTMC is helpful to guide the transeptal puncture.
Thank you, madam.
Any more questions or queries or comments from our presenters? Ishraq, you want to say something? We can see you.
Yeah, it's fine. It's
okay, great. So, Dhiman, any final words?
No,
or
no.
Kaleem?
Everything nice.
So we can conclude, right? So
yes,
thank
yes,
you.
madam.
Thank you, everyone.
Thank
So
you
we are
all.
leaving the
Right, bye.